last 2 months' time. And this session is going to be on rotator cuff tears. And the theme of the session is management of rotator cuff tears, and for which we have 3 speakers in that. And the 2 speakers are going to talk about evidences in managing rotator cuff tear. And the first speaker in that is going to be Dr. S.N. Lokesh Kumar, and who is a consultant orthopedic surgeon and assistant professor in SRM Medical College in Chennai. And he is going to tell about what is the role of surgery in partial cuff tears. And he will tell what the evidence says about that. That will be the first talk. And then after he finishes, second talk will be on managing full thickness cuff tears with just rehab. What is the literature saying about? And this speech is going to be given by Dr. K.S. Abhinandhan, who is a consultant orthopedic surgeon specialized in arthroscopy, shoulder, knee, and complex trauma and joint replacement. He is based at Hospet in Karnataka in Vijayanagar district. Welcome, Dr. Lokesh Kumar, and welcome, Dr. Abhinandhan. Welcome to our 3 series program. And then next is going to be experience and expertise talk from one of the senior most orthopedic surgeon, and he is from Amman in Jordan, and he is Dr. Ziyad El-Qirem, and he is going to tell about his technique of rotator cuff repair. He's going to share his experience. He is currently the president of Sports Medicine and Arthroscopy Association in Jordan. He is a consultant orthopedic surgeon and sports medicine at Amman in Jordan. So welcome to our program, Dr. Ziyad. Welcome to you. So this is going to be the gist of the program today. And I would like to thank Sun Pharma Group for sponsoring this program continuously on a regular basis. And also I would like to thank OrthoTV for channelizing this program. And with this small glimpse of introduction, let's go to the scientific program. And the scientific session is going to be to start with Dr. Lokesh Kumar first, and he's going to tell about role of surgery in partial cuff tear. The thing how it works here is after first talk, we can have few questions in the chat box and we can discuss about it. Similarly for the second talk also. At the last, when you finish the third talk, we can have overall full discussion. That is going to be the whole plan of the program. So let's start with the first talk now. This is going to be by Dr. S.N. Lokesh Kumar. Lokesh, are you ready to share your screen?
Good evening, sir. Yes, I am ready to share my screen.
Please proceed. Thank you.
Are you able to see my screen, sir?
Yes, we can see it. We are also audible very well. Please go ahead.
Good evening, one and all. I would first like to thank Professor K. N. Subramanian, sir, for giving me this opportunity to give a talk, the role of surgery in partial cuff tear. So my topic is the role of surgery in partial cuff tear, or the evidence says at present. So first let's go into the basics. What is the rotator cuff? Rotator cuff is made up of 4 interrelated muscles, basically arising from the scapula and attaching to the tuberosity of the humerus. The 4 muscles are supraspinatus, infraspinatus, teres minor, and subscapularis. And the long head of biceps acts as a functional part. So here you can see the muscles getting attached on the tuberosity of the humerus. So this is on the front view, the infraspinatus and supraspinatus, and back you can see the subscapularis. So basically, rotator cuff muscles arise from the scapula, supraspinatus arising from the supraspinous fossa, infraspinatus from the spinous fossa, and they are attaching on the superior facet and the middle facet of the greater tubercle. Teres minor attaches origins from the middle part of the lateral part of scapula and attaches on the inferior facet of the greater tubercle. And subscapularis attaches on the lesser tubercle of the humerus. So basically, you can see a clinical diagram showing the origin and insertion of the supraspinatus muscle. And this shows the infraspinatus muscle originating from the infrascapular fossa and attaching to the greater tuberosity of the humerus. Here you can see the teres minor and then the subscapularis. So basically, the function of rotator cuff is a dynamic stabilizer of the glenohumeral joint. The normal function of the shoulder is a balance between the mobility and stability of the joint. So function of rotator cuff, they are stabilizers of the shoulder, mainly anterior and posterior cuff, providing a fixed fulcrum for concentric rotation of the humeral head. They neutralize the shearing forces of deltoid in early abduction. They also initiate abduction and cause rotation of the shoulder. So the forerotator cuff supraspinatus muscle elevates the shoulder joint to the outer side. Infraspinatus muscle externally rotates the shoulder joint. Teres minor also externally rotates the shoulder joint. And subscapularis allows the humerus to move freely during the elevation of the arm. So you can see the footprint anatomy. You can see the supraspinatus muscle getting attached here with a footprint diameter of 14.7 mm, while the infraspinatus has a larger diameter of 1.76 centimeter square. And here you can see the supraspinatus muscle and the surface area of incision 1.5 centimeter. Here cross section showing the supraspinatus and infraspinatus muscles and the subscapular muscle. So in 1992, Clark and Neyman showed that the rotator cuff incision contains 5 distinct histologic layers. The second and third layers contain the tendinous fibers, whereas the remaining layers contain the articles and loose connective tissue. When you see a cut section of the rotator cuff, you can see basically make out 5 layers. Layer 1 contains the superficial fibers of the CHL or the coracohumeral ligament, and layer 2 contains the supraspinatus and its cuff tendons, parallel tendon fibers in line with the muscle belly. Layer 3 shows the thick tendinous structure, smaller fascicles, less uniform in orientation. Then the articular sided tendon. Layer 4 shows thick bands of collagen fibers running perpendicular. They have deep extension of the coracohumeral ligament, and they are basically described as a transverse band, a pericapsular band, or a rotator cable. Layer 5 is the capsular layer. So coming to partial thickness tear. Partial thickness tears of rotator cuff have the potential to cause a significant pain and disability in the affected patients. This literature says there's limited potential for spontaneous healing after development of a partial thickness tear. And this is in turn supported by histologic studies that showed no active repair at the site of injury. And the proximal stumps of the rotator cuff appearing rounded, retracted, and avascular. Clinical evidence of tear progression was shown by Yamanaka and Matsumoto in the evaluation of 40 patients with the documented partial thickness articular sided lesion of the supraspinatus. So all these cases progressed to a full thickness tear. So you can see MRI showing the partial thickness tear in the rotator cuff. So coming to classification, the partial thickness rotator cuff tears can be described as an articular sided tear, a bursal sided tear, intertendinous tear, or a combination of all these 3 patterns. So articular sided tears, they arise from the undersurface part of the tendon and communicate with the glenohumeral joint space. Bursal sided tears arise from the bursal surface and communicate with the subacromial and subdeltoid bursa. And the intersubstance tears confined to the tendon, and they are also known as concealed interstitial delamination lesions. But basically, caloric studies show that most partial thickness tears are intertendinous, followed by articular sided and bursal sided tears. Ellman graded it based on the depth of the rotator cuff thickness. Grade 1 was less than 3 mm or 25%. Grade 2 was 3 to 6 mm or 25 to 50%. And grade 3 was greater than 6 mm or greater than 50% tear. So this classifications for full thickness tear or partial thickness tear, they can be dependent on duration, acute or chronic, and degree of tear, partial or full thickness tear, etiology, traumatic or degenerative. And based on the size, they're like small, medium, large, and full thickness. So here are some types of the full thickness tears. You can see a crescent-shaped tear. You have a reversal and an L-shaped tear. Here we may have a trapezoidal tear and you have a massive cuff tear. These are full thickness tears. So coming to the incidence, Sher et al. Reported 20% prevalence of a partial thickness tear after doing an MRI study in 96 asymptomatic shoulder. So all these patients did not have any symptoms, but on MRI they picked up partial thickness tears in about 20% of the patients. A similar study done by Milgram et al. Showed using ultrasound in asymptomatic shoulders. They found of full or partial thickness tear of around 5 to 11%. 11% of subjects aging between 40 to 60 years. And this kept on increasing to about 80% in subjects aged older than 70 years. So patients more than 60 years of age had a 80% prevalence of a partial or full thickness cuff tear. Fukuda in his study reported that 73% of the patients with either a subacromial bursitis or partial thickness cuff tear reported more than moderate nocturnal pain, whereas only 50% of patients with full thickness tear report this much pain. So this shows that not only a full thickness tear but partial thickness tear also produces significant pain. So found that bursal sided tears produce notably more pain than
Stop charging after.
So coming to the causes of the tear, they can be classified either into an extrinsic cause or an intrinsic cause. So coming to extrinsic cause includes subacromial impingement, genohumeral instability, internal impingement, acute traumatic events, and even repetitive microtrauma. Intrinsic causes are most likely irreversible. They are decreased cellularity, vascular thinning and disruption, acclimation of granite tissue, and dystrophic calcification are usually seen in tendons having intrinsic causes for tear. Coming to pathogenesis of a partial thickness rotator cuff tear is likely end result of a common pathway. It involves both intrinsic and extrinsic causes. You just cannot point out one cause to be a ultimate cause for a partial thickness rotator cuff tear. Intrinsic causes include age-related metabolic and vascular changes, leading to both degenerative tearing and differential shear stress within the cuff tendons, leading to intertendinous tears. Coming to the extrinsic cause of partial thickness tears are not limited to only subacromial impingement, but they also include a variety of micro instabilities, repetitive microtrauma, acute events, and even internal impingement. So, what is internal impingement? Internal impingement is described most commonly in the overhead athlete, and it implies contact between the posterior superior glenoid and the articular surface of the rotator cuff at the supraspinous infraspinous interval. So, basically, the commonly seen in our patients who are overhead athletes and implies contact between the posterior superior glenoid and the articular surface of the rotator cuff, and this happens at the supraspinous infraspinous interval. Internal impingement is influenced by anterior instability, posterior capsular tightness, decreased humeral retroversion, poor throwing mechanisms, and scapular dyskinesis. So, partial thickness tears of the rotator cuff are a common source of shoulder pain, but yet treatment strategies remain highly controversial. Reports of substantial rate of clinical failure of treatment of smaller tears, as well as increasing evidence such as the patient age, may be a prominent factor affecting healing. So, many studies have shown that age to be the most common factor affecting healing. Coming to surgical debridement, studies of results after debridement alone have revealed a risk of progression to full thickness tears with little evidence of spontaneous healing. While local tendon injury and degeneration are invariably present, partial thickness tears are not associated with severe tendon degeneration and muscle atrophy that accompany larger full thickness tears. So, some studies have shown that the amount of degeneration in partial thickness tears is not as much as seen in full thickness tears. So, coming to the treatment of symptomatic partial thickness tears is controversial. Surgical strategies usually range from simple debridement and acromioplasty alone to aggressive surgical debridement and repair. Recent studies indicated that partial thickness tears have the potential to progress to a full thickness tear and that debridement does not alter the course. The literature suggests that the repair of partial thickness tears rotator cuff should be considered in articular shaded tears with the depth of greater than 6 mm and in bustal shaded tears with the depth of greater than 3 mm. So, completion of the tear followed by repair in the preferred manner, that is in all arthroscopic, mini open or open, should be considered when the tear is near full thickness and the remaining tissue is thin and keenness, or when there is a concomitant tear on the opposite side of the rotator cuff. Partial thickness tears are managed non-operatively by tailored rehabilitation. The range of motion optimization and rotator cuff and scapular rotator strengthening exercises are kept in the physio regimen. Anterior capsular tightness is addressed by external rotator stretching with the shoulder adducted, while posterior capsular contractures require stretching of the abducted arm and internally rotated arm. But poor results with conservative treatment for full thickness tears have been shown by Maman et al. And 52% progression over a mean 20-month period also leading to atrophy of the muscles seen in about 25% of patients. So, but similar study done by Safran et al. Showed that in 61 non-operatively treated symptomatic rotator cuff tears reported increase in size in about 50% of patients. So, non-operative management should be individualized considering patient expectations, symptoms, and response to previous non-operative treatment. Partial treated tears can be operated after a fair trial with conservative therapy. So, this was based on articles published in International Journal of Orthopaedic, surgical treatment options for a partial rotator cuff tear. Options available include the arthroscopic of debridement and open arthroscopic repair with or without subacromial decompression. Excellent postoperative outcomes have been reported in data from 16 studies, ranging up to 93%. Odasco et al. In 162 patients, either in a normal grade 1 or grade 2 partial thickness tear in an average follow-up of 4.5 years, reported significantly high failure rates in grade 2B, while the outcomes in grade 1, grade 2 and normal tests were not significantly different. So, grade 1 and grade 2 normal tests had no significant difference in outcome, but grade 2B bursal surface tests had a higher failure rate. the authors believe that the grade 2B Parcel surface tear may have better served with primary repair. So here they have suggested that instead of going for a conservative treatment, grade 2B Parcel surface tears should have been better treated with a primary repair. So some studies have even mentioned about arthroscopic conversion of an high-grade partial thickness rotator cuff tear into a full thickness tear followed by repair, producing high rate of tendon healing in patients for whom conservative treatment has failed. So in certain patients having high-grade partial thickness tear, they are even recommended to conversion into a full thickness tear followed by the repair, producing high rate of tendon healing. So of all the studies we have reviewed, age was significantly related to the successful repair of any rotator cuff tear. Tendon degeneration in the setting of a partial thickness cuff tear is usually focal, and the environment for healing following aggressive debridement and repair is more favorable than that for a larger full thickness tear. So partial thickness tear had a better healing rate compared to a full thickness tear, and you had a better environment for healing followed by aggressive debridement and repair. So here is one treatment algorithm published by Woolf and Roos. So here they shown that the partial thickness rotator cuff tear they initially managed with a non-surgical management, a minimum of 3 months. With symptomatic improvement, you can continue it. If there's no symptomatic improvement, you can do a diagnostic arthroscopy. And if it's a buccal-shaded tear less than 3 mm deep, you just did a debridement plus or minus acromioplasty. If greater than 3 mm deep, repair plus acromioplasty. If it was an articular-shaded tear and less than 6 mm in depth, debridement and acromioplasty was rarely done. Greater than 6 mm depth, repair was done, and acromioplasty was also very scarcely done. So one study had shown, published in 2012, if only conservative treatment fails after 6 weeks. Here in the study, the rotator cuff test should be considered. Treatment should be considered based on the risk and benefit of an operative session, non-operative treatment. The treatment depends upon the tear size and acuity, the patient's age, and all should be considered while making this decision whether you to go in for an operative treatment. In the study, the patient selection was done basically with only patients younger than 60 years were taken into the study, and they should have demonstrated clinically or arthrography demonstrable full thickness cuff tear, and they were also kept on non-operative management for 6 weeks and failure to improve with non-operative management. Repair of the tear was either done in open or arthroscopic and tendon to tendon or tendon to bone. And additional procedures were arthroscopic debridement, subacromial decompression, acromioplasty with mini open repair. So rotator cuff repair was initially based on the assessing the nature of the tear and amount of mobilization. The mobilization was usually done by releasing of the adhesions, release of coracohumeral ligament and interval side and subscapularis tendon transfer if needed. So the surgical options they had followed was debridement alone, debridement with arthroscopic subacromial decompression, open repair with acromioplasty, arthroscopic subacromial decompression with mini open repair. So this was an partial thickness tear before and after debridement. So currently there's no high-level evidence to support any specific treatment algorithm for partial thickness rotator cuff pathology. So the talk still continues whether partial thickness tears should be treated conservatively or should be managed initially conservatively followed by surgical repair. Thank you.
Thank you, Lokesh.
Thank you, sir.
I'll just check in the chat box. Any questions in there? So what is your inference then? In the sense, would you advise surgery at the early stage itself, or when would you advise surgery for a partial cuff tear?
Advice on surgery depends upon the age of the patient, symptoms of the patient, and order profession of the patient. So all the studies have shown that age is a key factor for surgical repair and improvement in symptoms. So younger age, and if a patient is symptomatic, they are advised to go in for surgical repair. And a patient who is an overhead athlete most likely is suffering from internal impingement syndrome. They are also advised to go in for early surgical repair. But patients who are in the highest status is above 70 years of age. Treatment has been advised because results of repair have been not so good compared to patients in the younger age group, sir.
The message is first treatment is rehab. That's what you're saying. Is it?
First treatment, initial rehab for at least 3 months. And if there's no symptomatic improvement, they are advised for going for surgery. And again, if it's a young athletic patient, overhead athlete, they are advised to go in for early surgery instead of waiting for 3 months for rehab.
Right. And there is a question in the chat box. During conservative treatment, what physiotherapy we can advise?
So one of the studies has shown that conservative treatment is tailored to every patient. It's not fixed to patients. So depending upon the patient's disability, it will be varying. So initially should be stretching exercise. So capsular type.
What the concept in rehabbing the partial cuff tear is, a lot of patients will have scapular dyskinesia. Hence, the primary step in doing rehab for these people is to get your scapula biomechanics correct. So, I would probably say that I would go for scapular exercises to start with, in the form of being strengthening 6 muscles mainly.
Strengthening 6. Initially, they have mentioned of range of motion exercises and scapular strengthening, rotation and strengthening exercises.
So I think Tarun has asked this. Tarun, the answer will be like focus on scapular exercise first, and then focus on rotator cuff isometrics, and then do stretching exercises, and then focus on the full range of movement. That is the order of sequence. And rehab will continue for a period of up to 3 months or even 6 months also, if they are improving symptomatically. So first, you check in about 5 to 6 weeks and see how they are improving. If they are improving well, continue the rehab. If they are not improving or sometimes they become worse, then you think about doing intervention. That is a usual scenario. Are there any more questions anywhere? Okay, thank you. I will go to the next talk and then stay in the on the online itself. So at the end, we'll have the full discussion. Okay. Yeah. So Dr. Abhinandhan is next going to give his talk. Dr. Abhinandhan, are you ready for sharing your screen?
Yes, sir. Yes.
Dr. Abhinandhan is going to talk on managing full thickness cuff tear with just rehab. What the literature says about it.
Sir, can you see my screen, sir?
Yeah, we can see your screen and you are audible very well.
Okay, sir. First of all, I would like to thank my mentor, Dr. K.N. Subramanian, sir, for giving this opportunity. So my today's topic is managing full thickness cuff tears with just rehabilitation. Let's see what the literature says. So most of the anatomy is covered by already Dr. Lokesh. So I'll just brush up. So rotator cuff originates mainly from the posterior aspect of the scapula, that is supraspinatus fossa, infraspinatus fossa, and the lateral broad of scapula. So insertion of the supraspinatus is around 6 to 12 millimeter, and infraspinatus is around 10 to 32 millimeter. So full thickness rotator cuff are further classified. Small tears can be said within 1 centimeter. Medium size tears are 1 to 3 centimeters. Large tears are 3 to 5 centimeters. And massive tears can be said which are above 5 centimeters. So what is the prevalence? Prevalence is about 9.7 to 62% depending on the age. It increases along with the age from 20 to 80 years. So I came across 3 meta-analyses which are done on the conservative management of the rotator cuff tears. So the first study says that there is a considerable excuse me. Hello, excuse me, I'm audible?
Yeah, you are audible, sir. You are audible.
My screen isn't moving.
It is on meta-analysis, sir.
Okay. So my first first meta-analysis says that conservative management is good until 12 months, and the second meta-analysis says that inconclusive results, and the third, which compares operative, it has a statistical significance over the conservative, but very little clinical significance. So what are the affecting factors? So first is integrity of intramuscular tendon of the supraspinatus. So in this study, they have divided the supraspinatus tendon in a coronal section of the MRI. So they say that layer 2 is of utmost importance. So if the layer 2 integrity is good, then the patient can be considered for the conservative management. And the second is supraspinatus muscle atrophy. So the ratio of the muscle thickness to the fossa should be more than 75%. If it is more than 75%, then the outcome will be good. So there shouldn't be any impingement side, and the external rotation usually should be more than 50 degrees. So out of all these four, if 3 are present, then the 87% is a success rate. So coming to site and number of tears, they in one of the study they have seen that isolated massive posterior tears do better than massive anterior tears, or tears which involve all the 3 tendons. So in one of the study, they have seen that infraspinatus muscle atrophy alone is an independent risk factor in tear progression in both anterior posterior and medial lateral direction. So there are one of the paper named the few negative prognostic factors. Let's see what are they. So first is glenohumeral arthritis. Second is a decreased passive range of motion. Third is superior migration of humeral head. Fourth is presence of muscle atrophy. And the fifth is external rotation and abduction strength, which is less than grade 3. So out of these 5, 3 or more are present, then the outcome will be usually poor. So what are the evidence says about the exercise protocols? So one of the papers says that first thing which has to be considered is the range of motion. This has to be improved. So in that range of motion, first is the glenohumeral motions, and the other is, second one is shoulder and thoracic posture. So first, after improving range of motion, second is flexibility. So flexibility is improving the tightness where the anterior and posterior capsule are relatively tight. So we have to improve the tightness. So next is the strengthening. So here first we have to improve the strength of scapular muscles, which are dynamic controllers, and improve the strength of anterior deltoid, and also improve the external rotation strength. So, and the fourth is advanced strengthening or proprioception. In this, the muscles which have been strengthened have to be relatively advancedly strengthened, and the work-specific or sport-specific exercises have to be considered here. So then, protocol. How about we go 6 phases? So there are 6 phases which is told to be considered in this paper. The first phase is correcting the scapular position, the scapular posture in the resting position. Second is incorporating scapular setting into motion. Third is incorporating humeral head control into motion. Fourth is progress into higher range of motion. The fifth is strengthening using weights from lower to higher ranges. And sixth is activity-specific exercises and the maintenance of those same exercises. So what is the rate of tear progression? In one of the paper, they compared and they found out to be almost similar rates in both asymptomatic and symptomatic rotator cuff tears. So how long the duration should be considered of the conservative treatment? If the patient is doing well for 3 months, then there are high chances that they do good at the end of 2 years. So effectiveness can be up to 75%. So in one of the prospective randomized control trial, home-based exercise therapy was good compared to the occupational therapy, as there were few psychological benefits in this. And one of the long-term study of up to 13 years said that 90% patients did well with conservative management, and out of that, 70% could do daily activities. And in one of the comparative study where they compared the surgical and non-surgical groups, so initially the non-surgical group did well compared to the surgical, but after 6 months, surgical group relatively picked up well. But at the end of 2 years, even the non-surgical group did not lag behind much. And the comparative study done in small and medium-sized states, here initially physiotherapy group did well, and at the 6 months they were almost same, and at the end of 12 months surgical group did well. So at the end of 6 months, there was no much difference between subjective and assessment. Both were relatively same, and they were compared on these platforms. So in one of the prospective cohort study, approximately 75% of the patients remained successfully treated with non-operative treatment at the end of 5 years, and reported a mean rotator cuff quality of life index score of 83 out of 100. So to conclude, what are the points to be considered before managing a patient conservatively? So first is the selection of the patient to be assessed after prior history taking and thorough clinical examination and complete radiological assessment. And the second is to consider age, affecting factors, risk factors, and prognostic factors. And the third is proper exercise protocol has to be recommended if we consider a patient for conservative management, and into different phases, as said before. And the last is a minimum of 6 weeks to 3 months duration has to be considered before recommending patients to the alternate treatment. So this is how we have to choose a patient for the conservative management. Thank you.
Thank you. Abhinandhan, good talk.
Thank you, sir. Thank you, sir. Thank you, sir.
Yeah. Let's see the chat box. See any questions in there.
Sir, you can stop sharing your screens.
Yes.
Not any, no new questions.
Okay, sir.
But Abhinandhan, what is your conclusion? Would you say that would you advise surgery immediately on seeing a full thickness cuff tear, or would you send them for rehab?
Definitely not, sir. First, we have to consider at least a physiotherapy round for 6 weeks, and we have to assess again. So 6 weeks assessment, we'll get to know how much the patient is undergoing pain and improving. So then we can consider till 6 months. Then we can note down all the on the parameters how the patient is doing. So if they are doing very well at 3 months, then there are high chances of they doing good at 2 months, 2 years. Sorry.
Take your point, definitely.
Yes, sir.
I think we are on time, 8:30 now. We'll move on to the next session, which is about experience and expertise talk. And this is going to be our expertise in the field, which is Dr. Ziyad El-Qirem. Ziyad, are you ready for your talk? Are you ready to share your screen?
Yes.
So he's going to tell about his experience on rotator cuff repair, his own technique, how he performs the surgery. Thank you. Dr. Ziyad, you please go ahead with your talk.
Hello?
Yes, sir. You're audible. Please go ahead.
You are audible, sir.
Yes. First of all, I need to thank the organizing committee to give me this opportunity to be one of these interesting programs. So my name is Ziyad El-Qirem. I'm from all the way from Amman, Jordan. So I will talk about a rotator cuff tear, and I will focus a little bit on practical points and reading MRI and how to think about the cuff, then on the techniques. So it's not working. I'm not sure why. Okay, so I have no my disclosure. There is no conflict in this talk. So this is a case studies here, and this is usually you see in your clinic that it's right shoulder pain in a middle-aged group. He's a professional general surgeon. The pain more than 1 year. One corticosteroid injection with a 10 times physiotherapy. Then when you go all the way to see the examination, it's a reasonable range of motion, which is very important to assess the range of motion in every single patient with the cuff pathology. Then he has a weakness. Usually I start with a simple x-ray. So what I need in the x-ray, I have to make sure that I don't have any arthritis, especially in the glenohumeral joint. Then I need to see if there's any migration in the humeral head all the way toward the acromion. So it's a little bit the distance between humerus and the acromion. Then go to the MRI. So the first step in MRI reading, so usually these are the patients with this cuff tear. So it's a small full thickness tear. Then this patient has pain, weakness. And if you go to another patient, he has the same small cuff tear, but maybe the weakness, less weakness and less pain. So is there any scientific explanation why some patients, they have a small cuff tear, they have a very painful range of motion, pain, and they have weakness, and the other one, they have less weakness, less pain. So when you go to the sagittal view, you can see the first patient has anterior fiber of the supraspinatus involved. In the second patient, you can see the middle fiber or the posterior fiber of the supraspinatus involved. So what does it mean? When you go back to the anatomy, the major contractile force is coming from the anterior fiber of the supraspinatus. So that's why give us explanation that when you have anterior fiber involved, that means more weakness. And also this is more affection of the cable. So this will give more weakness and more pain. And of course, when you see the geographic distribution of the GT or the greater tubicity, you can see there is a small area for the supraspinatus and big area for the infraspinatus. So we have to know exactly this distribution. So the second thing is when I go and examine the patient, I can see that this is a pseudoparalysis. And at the same side, I have to see the sagittal view. So I can predict that this patient has a pseudoparalysis when I see in a sagittal view that he has a subluxation. So it's very important to see if there is any subluxation in the axial view. So that's mean there is a bad force coupling. So what does it mean? That the pattracing between the anterior and posterior, and Stephen Beckhardt, he mentioned this very well, that the balance between subscapularis muscle and the upper fiber of the teres minor or the lower fiber of the infraspinatus, so mainly teres minor, subscapularis, you have to have a balance. So you have to keep the humeral head central. In this way, the deltoid will function very well. Otherwise, you will have subluxation anterior or posterior, depend about the weakness, either anterior or posterior, so the deltoid will not function very well. And this will give us explanation that we'll have some massive cuff tear with a good range of motion and some massive cuff tear with a pseudoparalysis. It depends about the force coupling. Other thing is that the fatty infiltration. So I have to stress on the fatty infiltration. Why? Why the fatty infiltration is very important? Because in this published in AGCM in 2012 showed that when you go more and more with the fatty infiltration, the musculotendinic junction will be more, and that's mean that the tendon length will be shorter, and it will be short as 1 or 1.5 centimeter when you have more and more higher Goutelier classification. So that's mean that chronic tendon tear are a tendon substance defect. So you cannot find a tendon tissue to repair it to the bone. So this is the most important thing, because you need a good healthy tendon tissue to repair. So another one trick that when you see a cuff tear, and this is published for a double row fixation, that the musculotendinic junction, if it's lateral to the glenoid face, this is one of the predictive factor that will give more and more healing. If it's medial to the glenoid face, will have less healing. So this is where you can give the patient some clues about the predictive value later on. Indication for the repair. So first of all, there is a pain for the rotator cuff. So I have to exclude adhesive capsulitis pain, and this is very important, or cervical spine pain. I saw a lot of patients, they have adhesive capsulitis, very small tear. So usually when you have a partial tear or a small cuff tear, this is sometimes associated with capsulitis pain. In a massive cuff tear, very rare to have a capsulitis because the capsule almost is not there, because it's a massive cuff tear. And of course, you have to make sure that it's not from the cervical spine. Second thing, the weakness, especially in the external rotation, abduction, forward flexion, and to make sure that it's a repairable cuff. Gerber showed in GSES in 2011 that if it's static and dynamic chronic subluxation, this is irreparable. And if it's chronic pseudoparalysis, it's irreparable. And if it's chronic dropping arm sign with a high fat infiltration rate, this is irreparable. And if it's chronic hornblower sign, this is irreparable. But this is published in 2011, but nowadays still we can do something in these things. And this is what you call the entity, how you can reverse mania. So sometimes with a partial repair, superior capsular reconstruction, biceps buttressing, still you can do some sorts of repair. So it's not an absolute indication or a contraindication to do repair. It's very important to understand what does it mean that excessive tendon tissue, and this is what we call a dog ear. So you don't need to have a dog ear in your repair, because this will decrease the healing, affect the tension, make sometimes a chronic pain. So you have to understand the anatomy of the rotator cuff and the distribution of the GT to have a good repair without excessive tissue above the greater tuberosity or even the lesser tuberosity. It's very important to know about the double layer structures. As mentioned before, that we have a superior layer and we have a deep layer. So in my practice, usually I use, so this is a patient with a chronic tear with a double layer. And you can see this layer, usually I use a special lasso loop for the deep layer to make sure that I have a very tight construct that I can bring it down all the way in the medial side. So I use this lasso loop I take one suture from the medial anchor to do a lasso loop in this one to make sure that I stabilize the medial or the deep layer, which is very important for repair and healing. Single or double row, there's a lot of debates about these things. I think there is no winner, but you have to understand that the significant higher tendon integrities with a double row than a single row. But this is does not mean that it's always the winner. Going for this studies in GSES in 2007, that the transosseous equivalent, they have a very high pressure distribution compared with a single row or just a medial row. And also going to my technique or my portals and position. In the beginning of the surgery, I have to do manipulation for each patient. Why I do this? Because if you have some source of adhesions, which is very minimum, this will give us more and more decreased pain, and this will give us a good rehab after that. So I do manipulation for each patient with the rotator cuff. Then I use my regular portals. So if you can see, I have mainly 4 portals: posterior, posterior lateral, anterior lateral, and anterior. So my trick in rotator cuff for the posterior and anterior portal, I'll do it more superficial and more medial, because this is where you can do suture passing easier when you have more medial and more superficial. Then I use all my rotator cuff surgery with bead chair. For the intra-articular stuff, I do it in lateral decubitus. So in my technique, I have to think about the long head of the biceps. Should I leave it? Should I do tenotomy or tenodesis? Usually in a massive cuff tear, I do tenodesis in the intra-articular part. If it's small, I'll do suprapec tenodesis. Then I have to do exposure for the scapular spine. Why? First of all, most of the bleeding is around the scapular spine. The second thing, this is where you have divergence between the supraspinatus and infraspinatus. So you can see exactly where is the supra and where is the infra, because on the lateral side, there is a conjoint tendon. So you need to have exactly where each tendon go from where. And I have to inspect the tear. Is it come from anterior, come from posterior? Usually, the infraspinatus go from anterior to posterior, so you have to bring it from posterior part. Then I have to do a good preparation for the footprint. So in my tip here, that when you have a double row fixation, you need to prepare mostly in the lateral side of the footprint, because you don't want to violate the medial side and decorticate the medial side. Sometimes you will not have a good enough bone to stabilize the angle in the medial side. Then either you do a medial row or lateral row. It depends about the tendon pattern. Then at the end, I'll do acromioplasty. So first of all, for the release, it's very important to do a proper release for each cuff. So you can see this is mostly a double layer. It's not too much retracted, but still I have to do some sorts of release. I start with intra-articular release, which is just above the labrum, below the cuff itself, and this is the first part of release. And sometimes I start with the extra-articular part. Then I have to go to expose the base of the coracoid. Why to expose the base of the coracoid? Because there you can find the glenohumeral ligament. And this is a study that we did it in the cadaver lab, that the coracohumeral ligament, when you cut it, you will gain more and more external rotation, especially in the adhesive capsulitis, and you will gain more and more traction for the supraspinatus. Then I'll go all the way to the base of the coracoid. Then I start to prepare the footprint. So there's another trick we call the side-to-side repair, and especially when you have a defect in the tendon. So you can do one trick that you will go to do a side-to-side repair, and this will decrease the distance and bring the tendon all the way toward the tuberosity and toward the footprint. So I call this as a speed fix. When you have a small cuff tear like this, I will do, and sometimes the medial row it's there, I start to do prepare the bed and do a microfracture. So it's very important to see that the microfracture, you don't need to use the same microfractures of the knee. Sometimes you need to do a nanofractures. You need a smaller hole, and this will bring more and more growth factors. Then I start to do a inverted mattress. Why I do inverted mattress in a single row fixation? Because I don't want to have any tissues between the cuff and the footprint itself. Then after put all these sutures, I start to put my anchor just below the greater tuberosity. And you can see between 1 or 1.5 centimeter below the greater tuberosity. And I'm trying to secure in a good bone tissues. So for the double row, this is a classical teaching. You put a medial row in the medial side of the greater tuberosity. Why sometimes I use a double row, especially if you have a retracted cuff? You have to learn more than one type of suture passing, either lasso or peak or rhino or clever hook or scorpion. So you have to learn more than one technique, because you don't know which one is suitable for that tissues. Then I start to do my medial row, tying this all the way in the medial side, then bring it to a lateral row. It depends about 1 anchor, 2 anchor. It depends about the retraction, and it depends about the distribution of the footprint itself. So for the retracted one, I use a Devereux technique. So for the microfracture, as I mentioned, there's a significant lower re-rupture rates after 2 years, especially when you are doing a single row technique. And also I do acromioplasty. The main cause for acromioplasty is to increase flushing of growth factors. So this is the main reason I do acromioplasty after rotator cuff tear. So going to my choice, so I'll do, if it's retracted, I'll do a double row. If it's not retracted, but small, I do a speed fix, which is just a lateral row with the inverted matrix. If it's large, I do what you call a speed bridge. This is medial anchor, but without knot tying in the medial side, then with the lateral anchor. Usually in the post-op protocols, now I'm starting to be a little bit more aggressive. So I put the arm sling for 5 to 6 weeks, but I start passive range of motion. So I will let the family to start to help the patient to do a passive range of motion after 2 weeks. And of course, no weights till 3 months. So I start to resistance or weight after 3 months. So take-home messages, you have to examine the patient very carefully. So you have to exclude cervical pain, adhesive capsulitis pain. It's very important to look all the sequences of the MRI. Sagittal one is very important to pick where is the tear, is it anterior or posterior, and to see the axial if there is subluxation or not. Major contractility force, it's from the anterior fiber with the supraspinatus, and I've seen a good number of patients without pain, without symptoms, and they have a full thickness tear because it's away from the anterior fibers of the supraspinatus. Do a proper release of the cuff. It's very important to have tension-free cuff repair. You have to learn more than one method of passing sutures because you're going to stuck, especially in massive cuff tears, double layer. It's not easy sometimes to pass a suture. And at the end, you have to think about the biological augmentation with microfracturing, sometimes a PRP and other biological augmentation. Thank you.
Thank you, Dr. Ziyad. I think you said everything short and crispy. Very nice. Thank you.
Mm-hmm.
Sir, you can start sharing your screen, sir.
Yeah. We'll go on to some discussion if there are any questions. I think if you see in the chat box, there's one surgeon has asked about what do you mean by single and double row repair. I think it might be good to explain because there are a lot of postgraduates in our in this also, so they may not be knowing about single row and double row.
Okay, so usually the footprint it's wide. So if you put one anchor close to the articular surface and you just use this anchor, this is called a one medial row. But if you use a one anchor in the medial side, then you take all the suture from that anchor all the way below the greater tuberosity. This is called a double row, which is a lateral row. So we have a medial row, which is close to the cartilage. And we have a lateral row, which is below the greater tuberosity. So any anchor in the footprint itself, this is considered a medial row or single row. Any anchor below the greater tuberosity, this is part of the lateral row. If it's alone, called single row. If it's with the medial row, called double row. So that 2 point of fixation, this is double row. 1 point of fixation, this is single row.
Nicely explained. Thank you. Yeah. What is your take on Ziyad? Can you hear me?
Yes.
Yeah. What is your take on doing all these procedures like superior capsular reconstruction, latissimus dorsi transfer for massive cuff tears? Those who are, we're talking about irreparable cuff tears.
Yeah. So you mean what's the indication? You mean?
Yes. Yeah.
Okay. So this is a very good question. Actually, if I have a young patient and this patient has a positive Hornell blower sign that the teres minor is not functioning. So this patient, for sure, he has some sort of called pseudo-paralysis. So when you have a pseudo-paralysis in patient with a young age, And I will not think about arthroplasty because we know that the reversed shoulder in a young age, they are not doing great. So we have to have a tendon transfer for the external rotator, and this is will restore the force coupling. So as I mentioned before, you have to have a balance between the anterior and posterior. So one step, it's called to restore the force coupling. When you restore the force coupling, will make the deltoid will function very well, and will improve the range of motion. If we need to add more in this kind of patient, more and more increase range of motion and decrease pain, we add superior capsular reconstruction. But the second scenario is if we have a good range of motion patient, but he has a massive cuff tear, when we do X-ray and he has a migration of the head, but he has a very good range of motion or acceptable range of motion. So at this time, we have to think about partial repair plus superior capsular reconstruction. But we have to think about the glenohumeral arthritis. If we have arthritis, it's a game over. We cannot do anything. It's a cuff arthropathy. But if we have a still young patient or relatively young, active guy with a good cartilage, and he has a reasonable range of motion, but still he has pain, weakness, we can add a superior capsular reconstruction. But if we don't, at this time, we have to make sure that he has a good force coupling. The superior capsular reconstruction with a bad force coupling will not do a great job. So we should have a good force coupling. So that's why the axial cut of the MRI will give you a clue about the force coupling, and the examination of the patient will give you a clue about the force coupling. So it's very important to assess which patient will be suitable for this type of procedure. The question always, and there's no study in the literature yet, is there any comparable studies between partial repair alone with and partial repair with adding superior capsular reconstruction? So is there a huge benefit of superior capsular reconstruction with a partial repair, or we just like a very minimal improvement? Still in the literature, nobody did this study because most of the time in the United States, if you do a repair and you can do superior capsular reconstruction, you have to add superior capsular reconstruction. So you cannot leave this without a superior capsular reconstruction.
I think you are absolutely right, because there are studies which have shown about partial repair. There are separate studies and separate studies for SCR. There are no studies which has compared both procedures together. And my take is like they are roughly around 70 to 75% outcome, not the 95% outcome. Whether it is a partial repair or SCR, both of them will have similar kind of outcome like 70 to 75% only, not 95, 100%. So the important thing is we have to counsel the patient, making sure that they are fully aware of the outcome of the procedure that we are doing. That's what I would also think about. There is some question in the chat box, which maybe everyone can answer about it. Dr. Sagar has asked about what is your take on managing symptomatic partial cuff tear in diabetic patient who are also having adhesive capsulitis. I think my take will be first to do rehab for these patients. A partial cuff tear in diabetic and having adhesive capsulitis. I would not be jumping on surgery for these patients. First management will be doing a rehabilitation, and the rehabilitation will be in the form of correcting scapular kinetics and then doing rotator cuff isometrics and then going for range of movement by doing stretching exercises and then going for active movements. So over a period of about 6 weeks to 3 months, do a slow and gradual rehab. You can also use modalities, and also absolute control of diabetes is also essential for these patients. Do you have any other points to add up? Abhinandhan?
Sir, we should see mainly the pain is where is it arising from? Is it because of capsular tightness or it is because of rotator cuff pathology? So usually diabetic patients will have capsulitis. So firstly, we have, as you said, you have to see on improving the range of motion, scapular strengthening exercises, then the flexibility of the joint. So if all this is done, even after that, if the patient is having symptomatic, so after 3 months, we can reassess and we can reconsider if he is eligible for the surgery or not.
Correct. There's one more question has appeared in the chat box. Pasta lesion is the same as partial thickness tear. Any one of you can explain it? Oh. Okay, pasta is basically partial articular surface tendon avulsion, which is by itself, it means partial lesion only. So it comes under the umbrella of partial thickness tear only, but the majority of the pathology will be in the articular side. That's what it means. So this is a simple explanation of what pasta lesion means. And young pasta lesions might be worth doing a repair. Patients who are young, sporty individual, traumatic onset, pasta lesion is worthwhile doing a repair. Insight repair will be very useful for this. There's Dr. Ziyad, there's a question about subscapularis repair, tips and tricks. You want to add anything further?
Yes. First of all, for the subscapularis, in the beginning, in the past, when I did my fellowship in New York University, we started to do the subscapularis from the intra-articular part. Then when I saw a lot of French surgeons, this is what you call outside of the box, which is you see the subscapularis from the subacromial space. So first of all, you have to always see the subscapularis intra-articularly. So there is a trick how you can see the subscapularis intra-articularly, because you are viewing from the posterior portal. You have to tilt the light source all the way toward the biceps and see the insertion of the subscapularis and to see the biceps pulley, because we know the anterior pulley is almost a subscapularis, part of the subscapularis. So we have to make sure if there is a subluxation of the biceps or not, is the pulley it's affected or not. So if there is a partial tear or if there is a almost a stage 1, still you can do repair intra-articularly, because you cannot do or you cannot see everything if it's just a stage 1 with almost a good intact of the supraspinatus. But if there is a massive cup tear with the subscapularis, you have to go outside the box, which is from the subacromial space. So trick number 1, your viewing portal, it's the anterolateral portal. So you have to put your camera into the anterolateral portal. Trick number 2, you're releasing suturing, it's the anterior portal. So you need your anterior portal superficial and medial as much as you can. Then you have to see all the way toward the coracoid. So there is a 3 side of release of the subscapularis. You need to release it posterior to the subscapularis. I mean, between the anterior labrum and the subscapularis. So you have to release this one. So the question always, till when I can do release to see the middle glenohumeral ligament. So usually the middle glenohumeral ligament is sagged all the way medially. So you need to do release till you see the middle glenohumeral ligament. Then you have to do superior dissection, which is just below the coracoid. Then you have to do anterior release, which is anterior to the subscapularis, posterior to the conjoint tendon. When you are doing anterior release, you have to do flexion of the shoulder. So this is very important trick. You have to do flexion of the shoulder, and this is will open the whole area in the anterior part. Then you have to start to do your release all the way. When you go more and more medially, you will see the axillary nerve there, because the axillary nerve will be medial to the coracoid, crossing all the way the subscapularis, going to the inferior border of the subscapularis. So you have to be aware about medial release for the subscapularis. Then either you do a single row or double row. It depends about the retraction. If it's stage 1, it's more 1 row more than enough. If it's stage 3, 4, you have to add 2 row, because the footprint of the lesser tuberosity, it's very big. It's very big. It's like the GT, actually. So you have to put double row fixation. It's a very power muscle. I think I started to understand subscapularis when I started to do arthroscopic suprapectoral biceps tenodesis. So try to learn yourself to put your camera in the anterior lateral part, try to clean from the posterior portal, then make your anterior portal and try to find the biceps groove. It's always there. You can just feel it. Everything anterior to it, this is part of the subscapularis. Everything posterior to it, this is part of the supraspinatus. So this is where you can just find some landmark for the subscapularis. But I think it's one of the most difficult to repair when you compare to the orientation and how you do release for the cuff.
Great. I think you covered all the topics for subscap repair also. There is a question on portals for rotator cuff tear. I think portal for rotator cuff tear is a conventional portals or posterior portal, lateral portal, and anterior portal. These are the three portals that everybody makes, and there's a workhorse for all. And one will be the weaving portal, and another will be the working portal. And then depending on the location of the tear, you make accessory portals. Accessory portals will be posterolateral or anterolateral. So I make portals depending on the location of the tear, and may use a needle for that, and then use a stab incision, and then introduce your instrument. That is the way you go with the rotator cuff portals. So usually about 3 or 4, sometimes you need to have 5 to 5 portals also, depending on the size of the tear. And there's a question about biceps tenodesis. What is the indication? Anybody wants to answer? What is your indication, Ziyad?
Yes. Actually, for me, if you have a rotator cuff tear, microscopically, the biceps is involved. So I will not leave the biceps alone because I don't want my patient to come back with just anterior pain without doing anything for the biceps. So I have to do something for the biceps. Almost 90% of the patients, I do something. So tenotomy, the classical teaching tells 60, above 60 do tenotomy, below 60 do tenodesis. Actually, it depends about the activity or the level of activity of the patient. Still, I have some patients like 65, they are tennis player, they are very active, so I do tenodesis for them. The question is, what is the level of the tenodesis when you are deciding to do a tenodesis? If there is a massive cuff tear, I mean the posterior bully involved, I will take just one suture from the anterior anchor and put it with the tenodesis for the biceps. But sometimes there is a small cuff tear, either in the supra or supra-infra, and the pulley, it's not involved. So I'll do a separate suprapectoral arthroscopic tenodesis, and I'll do it just above the pec major. And this is usually doing great because we overcome the whole groove. So I will get rid of the groove because most of the pathology from the groove itself. So it depends. If it's massive, I will take one suture limb from the anterior anchor for the supraspinatus and I do tenodesis. If it's a small cuff tear, I'll do a separate arthroscopic biceps tenodesis, just suprapectoral. But in general, almost in every patient with a cuff tear, I'll do a biceps, either tenodesis or tenotomy.
Thank you. Great. I think good discussion. Let's see, is there any more questions? If there are no more questions, it's coming to the time for conclusion. And are there anything anybody wants to add? Okay, pin drop silence. So it means everybody is satisfied. Okay, thank you. So I would like to thank all the participants who have been in this program now and who are also going to watch in OrthoTV and also in YouTube. I thank all of them. And I'd like to thank all the faculties who have done their job today. Fantastic. The contribution is really wonderful. Thank you, Dr. Lokesh Kumar. Thank you, Dr. Abhinandhan. And special thanks to our guest speaker from Jordan, Dr. Ziyad El-Qirem. Hi, thank you very much.
Thank you so much. Thank you.
Thank you to OrthoTV channel, and thank you Sun Pharma team for continuously sponsoring this. So thank you one and all for everyone. So keep
Thank
it.
you, sir. Thank you.
Thank you.
Thank you, sir.
Thank you. Thank you.
Thank you.
Thank you.
We can